Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Dr. Christian Ruff in Boston, Massachusetts, and Dr. Sander van Doorn in Utrecht, Netherlands, in order to discuss traditional and potential future options for anticoagulation in patients with atrial fibrillation based upon their FRAIL-AF and AZELEA studies. Dear Dr. Ruff, dear Dr. van Doorn, thanks so much for joining us. It's a pleasure to host you.
Thank you.
Thank you.
Good morning, good afternoon also from my side. As a brief introduction, Dr. van Doorn is Assistant Professor at the Department of General Medicine and Nursing Sciences at the Julius Center for Health Sciences and Primary Care at the University Medical Center Utrecht, as has already been said. And he's one of the co-investigators and leaders of the FRAIL-AF trial, which interests us a lot because it examines the way we maybe have to change or not change and switch vitamin K antagonist-based oral anticoagulation in old and frail patients to a non-vitamin K in certain populations. So we're very, very keen on your results and the discussion there. And then Dr. Ruff, I don't think needs much introduction. He's Director of General Cardiology at the Cardiovascular division of Brigham and Women's in Boston. And he's one of the senior investigators of the TIMI study group. And he's the PI of the AZELEA study, a large but a phase 2 study investigating one of the novel factor 11 antagonists, abelacimab, for stroke prevention and atrial fibrillation. So that might be the way oral anticoagulation will go towards in the future or not. And we'll discuss that. And we are very happy to have you both here. And maybe start with the FRAIL-AF trial with a short presentation and discussion then. Dr. van Doorn, please.
Thank you. So it's my pleasure to discuss with you the results of the FRAIL-AF trial on the safety of switching from a VKA to a NOAC in frail older patients with atrial fibrillation. And I will present these slides on behalf of my dear colleagues, Ms. Linda Joosten, she's the PhD student and the first author of the manuscript, and Dr. Geert-Jan Geersing, the principal investigator of the FRAIL-AF study. So I have nothing to declare. A little bit of background on frailty. This is what it's all about. So frailty is more than just advancing age or multimorbidity or polypharmacy. In fact, frailty is a very complex clinical syndrome that is characterized by a high biological vulnerability, a low capacity to resist stressors, and a high dependency on significant others. Now, frailty in itself is very common in the population, with a prevalence of about 12%, and this prevalence is increasing with an increasing and aging population. And the prevalence of atrial fibrillation is very common in frail older people, with about a prevalence of about 18%. And it is in particular in these frail older patients with atrial fibrillation that the risk of ischemic stroke is very high. And of course, especially in these patients, we need effective but also safe anticoagulation. Now, we all know that the guidelines recommend NOACs as the preferred anticoagulant, especially in new patients with atrial fibrillation and in those patients on a VKA with a low time and therapeutic range. If we look at frail patients in particular, we have the 2023 ERA expert consensus document on the management of the frailty syndrome and arrhythmias. And they state that the advantages of NOACs relatively to VKA are likely consistent in frail and non-frail F patients. However, these recommendations are not very strong because direct randomized evidence in frail patients with atrial fibrillation is lacking. And that is why we designed the FRAIL-AF trial. And it aimed to address the following research question. Does switching from a VKA to a NOAC compared to continuing a VKA reduce bleeding in frail older patients with atrial fibrillation? The FRAIL-AF trial was performed completely in the outpatient setting, and we included patients when they had a score on the Groningen frailty indicator, a measurement for frailty of 3 or higher, and when patients were 75 years of age or older and used the VKA for non-valvular atrial fibrillation. Patients with renal failure were excluded from randomization. In the intervention group, patients switched over from a VKA to a NOAC, and the choice of NOAC was left to the treating physician. Most of the times, this was the general practitioner. Patients in the control group continued their VKA treatment and were managed by the local thrombosis services. The primary outcome in the FRAIL-AF trial were major or clinically relevant non-major bleeding, Secondary outcomes included thromboembolic events and all-cause mortality. A little bit more on these outcomes. We used the definitions by the IHTH, stating that major bleeding was any bleeding in a critical area or organ, any fatal bleeding or bleedings leading to a transfusion or a fall in hemoglobin level. Clinically relevant non-major bleedings were all bleedings not being major, but at least prompting a face-to-face consultation, hospitalization, increased level of care, or a medical intervention. So the FRAIL-AF trial was an investigator-initiated, randomized, pragmatic, multi-center, open-label superiority trial with 1 year of follow-up. Funding came from the Dutch government, and in addition, we received unrestricted educational grants from the 4 DOAC companies. On the right, you see a map of the Netherlands with the dots indicating the thrombosis services that recruited the patients. So for the statistical analysis, the trial was analyzed as a superiority trial, and we estimated to need about 2,150 patients per treatment arm. The protocol prescribed an interim analysis after 160 primary outcome events would have occurred, after which the Data and Safety Monitoring Board could advise to halt or modify the trial. All analyses were Cox regression analyses on an intention to treat basis, with death as a competing risk. So here you see a flowchart of the included study participants. We randomized 1,330 patients across both treatment arms. And in the bottom of the chart, you see that in this population with frail older patients during a COVID-19 pandemic, loss to follow-up was low and adherence to the protocol was high. Here are some baseline characteristics of the study population, and you notice straight away that this indeed was an old and frail population. The median age was 83 years old, which is nearly 10 years older, or maybe even more than 10 years older than in the landmark NOAC trials. The median score on the chronic and frailty indicator was 4, and the median CHA2DS2-VASc score also 4. In the intervention arm, most patients switched over from a VKA to rivaroxaban in about half of all patients. We also see that off-label dose reduction of the NOAC occurred only in a few cases, under 7%. So now for the results. So we designed this trial as a superiority trial with the hypothesis that switching over from a VKA to a NOAC in these patients would lead to less bleedings, but we observed the opposite. So after the interim analysis, the pre-planned interim analysis, the Data and Safety Monitoring Board advised to halt further inclusion, because switching from a VKA to a NOAC was clearly associated with an increased risk of bleeding with a hazard ratio of 1.69 and a p-value of 0.001. If we look at the separate components of the primary outcome, we see that this difference is mainly driven by an increased risk of clinically relevant non-major bleedings. As for the secondary outcomes, we did not observe a statistically significant difference between the groups in thromboembolic events or all-cause mortality. So FRAIL-AF was a unique study. It was the first randomized NOAC trial that exclusively included frail older patients. And we conclude that switching from a VKA to a NOAC should not be considered without a clear indication in frail older patients with AF, because it is associated with the 69% increased risk of bleeding with NOACs. For any further details, I would like to refer you to the publication in circulation, and thank you for your attention.
Well, thank you very much, Dr. van Doorn. Very, very interesting study, very clinically relevant in everyday practice. Dr. Ruff, may we ask you to, maybe also from an American perspective, on your thoughts about the study?
That's a great study, and thank you so much. A really important contribution to the field, because obviously these patients were relatively underrepresented in the individual trials, and clearly a patient population that's very vulnerable both to the risk of thromboembolism as well as bleeding. And I did have a question. You know, one of the things that we know about the DOACs versus warfarin is that they are relatively similar with respect to their stroke prevention, but there was statistical heterogeneity with respect to their benefit for major bleeding, in particular gastrointestinal bleeding, which, as you know, is 2/3 or so of the bleeding we see with DOAC therapy. And I did notice that the majority of patients, or at least half, were on rivaroxaban, and that agent, clearly is no better for major bleeding than warfarin, and significantly worse for GI bleeding, which would be quite high in this population. In the U.S. practices, certainly in these older, frailer patients, there's much more use of the DOACs that had significantly less major bleeding than warfarin, in particular apixaban and edoxaban, and those two agents had at least 20 to 30% less bleeding. So do you think some of the results were driven that if you did have a frail patient, clearly they are doing well on, and they've done well on a vitamin K antagonist, that it might be reasonable to keep them on that, but also if you were to switch them, you really would want to pick the safer DOACs, and some of the bleeding here was really driven by the majority being on rivaroxaban and then some proportion being on dabigatran, and obviously those two agents you might want to avoid in this population as well.
Yeah, that's an excellent remark, Dr. Ruff. Thank you very much. Indeed, this study was not powered to show any difference between the NOACs. So let me state that foremost. We did not, because this was a pragmatic trial, and we left the decision on which NOAC to switch to the treating physician. It could very well be that some of the results are influenced by the high number of rivaroxaban use in the intervention arm. I'm reluctant, because we're not powered to show any difference. I'm reluctant to say that may be one of the NOACs to avoid. We did see in some non-pre-planned exploratory sensitivity analyses that there wasn't major differences between the NOACs, but of course, I think I completely agree that there may be some differences also in this frail population. Yeah.
So just one follow-up question, just, obviously with the power, the one endpoint that would be hard to ascertain with any confidence was intracranial hemorrhage. That benefit was fairly consistent across the DOACs versus warfarin in all sorts of populations, about 50%. Relatively rare, obviously, in patients on DOACs or patients who are well controlled on warfarin. And so I guess the one other question is that if the bleeding you were concerned about in a frail patient was intracranial hemorrhage, that benefit may be preserved. I think with the DOACs might be harder to see in any trial this size, but certainly for major bleeding in general, the results I think are really an important contribution.
Thank you. Yeah, thank you.
Do you have any? I know the numbers probably are too small, but what about subgroups on the low dose of the rivaroxaban, or on other confounders such as renal function? Is there a hint, a hypothesis generating result that could maybe point towards a direction? Because 20 milligrams rivaroxaban, I completely agree with what Dr. Ruff said. We wouldn't really want to give that to an older, frail patient.
Exactly. So again, this was a pragmatic trial. Most of the dosing was left to the treating physician. If the dosing was really off, and by that I mean usually if a dose reduction should have been applied and it wasn't, we usually advised the treating physician to pick the lower dose. We did do some exploratory sensitivity analysis where we didn't really find any clue on either renal function or we didn't do on the DOAC dose, and then the numbers were actually too small. This trial could be an argument, and of course this is just a hypothesis, to extend the criteria for dose reduction a little bit, and even if you don't meet the exact criteria for dose reduction, at least consider maybe or do some research on what a lower dose would achieve in these patients.
Particularly after the results of the elder care study, which, even though not licensed in that dosage in Europe, and I guess also not in the US, suggests that very low dosages of NOACs may still keep some beneficial effects while lowering the risk of severe hemorrhages. I have two questions on that as kidney doctor, surely. So you excluded patients with CKD stage 4 and 5 with creatinine clearance below 30. And these might be the patients that may particularly benefit from NOACs. Just a few days ago, the KDIGO recommendations now list vitamin K antagonists as nephrotoxic. So here, might be a particular benefit, even though I'm aware that there are no good data on that. And so my first question, what would you do in those elderly frail patients with severely impaired kidney function? The second and last question from my part would be, follow-up was quite small because you had to stop the study prematurely because of your interim analysis. So might it be, and this is surely pure speculation, that with a longer follow-up, adverse events of vitamin K antagonists may have become more evident?
Yeah, these are two, I think, very valid points. So the first one, of course, this is speculation. There were no severe kidney failure patients in the study. If they do well on a VKA, myself as a general practitioner would probably not switch them over. But of course, the key here, and that is whether they're on a VKA or a NOAC, is that you just need very careful monitoring. And that's what we also find in other trials, particularly on integrated care for patients with atrial fibrillation. And we saw that the most vulnerable or frail patients benefit the most from integrated care, careful follow-up, measuring of kidney function. I think if they are doing well on a VKA, I would probably stay with that treatment plan. And yeah, it's up to the doctor and the patient to decide whether if there's something, if they don't like anything with the VKA, whether switching to a DOAC would be an option. As for the second question, indeed, we do only have 1 year of follow-up. It's good to realize that we halted inclusion, but continued follow-up until the last patient was followed. The follow-up for 1 year was planned. We have some, we're looking into opportunities to do a study with an extended follow-up in these exact patients. On the other hand, from randomization up to 1 year follow-up, we see the lines in the incidence curve diverging. So it could very well be that we will not see a catch-up effect in VKA patients later on, but that's just speculation. We need to study longer follow-ups. Yeah. Valid points.
I would also like to add 2 more questions. So thank you very much for the great presentation and congratulations on this beautiful trial. You discussed the time in the therapeutic range, and I'm pretty sure it's not everywhere the case, as in your study, that the patients have a very high time in therapeutic range, as it cannot be controlled that regularly in some certain situations. Could you maybe elaborate on that a little bit? How important is it to have a certain amount, a certain number in this range?
Yeah.
And my second question, the question of all questions actually would be, why is it that frail old patients apparently do not benefit from NOACs?
Yeah. So maybe start with the easy question then first. So what we saw that with the time in therapeutic range in these patients, we unfortunately did not measure it, and in hindsight we should have probably undertaken effort to do that. It was about 70%, so it was good, not perfect, but it was actually good. So that could at least be a little bit of an explanation of why we see this. And of course, I think for patients that are well controlled in VKA on a VKA with the time of in therapeutic range above 70%, then probably VKA for these frail old patients is perfect. If you cannot control the TTR, maybe even with the results of the FRAIL-AF trial, you could also always consider to carefully, with the right dose, switch over to NOAC if the TTR remains a problem. As for why we see what we see here, I think, well, there's a lot of hypotheses, but I think for me the most important are 2. One is that these, of course, are patients that were well tolerant to VKAs, so they were usually on a control of the thrombosis surface for many years. And what we then see, if you change over to any new treatment, of course, you may end up with side effects, and the side effects of anticoagulants are bleeding. So that is, I think, one. So these are these are patients that tolerated VKAs very well. And the second is probably also a biological explanation, where the biological availability or the fluctuations in biological effect of the NOACs is more pronounced in these frail patients due to renal function, polypharmacy, and any other interactions that we may not see as much in non-frail patients.
I have two maybe last questions, or not last, before we go further and hand over to Dr. Ruff. One thing is the somewhat special situation in the Netherlands. You already alluded to the Thrombosedienst. How much of a role does the regular visit to a, maybe not a doctor, but a nurse play here? I mean, endpoint was bleeding. Bleeding cannot be affected so much. We have other studies on rheumatoid mitral disease where one speculated that possibly the mortality lowering was just because the patient went to the doctor more often. That's probably not the case here. What's your thought on that? The other question is, when did the events occur? They occurred looking at the Kaplan-Meier curve during the course of the study. So it's not that the switching itself was a problem because we interfere with the hemostasis and the well-controlled situation, is it?
Yeah. Now, so to address your first question first, I think what we found, and that was actually surprising to me as well, that most of these patients, they know their way to the thrombosis services very well. As soon as something happens, even when they switched over to the NOACs, most of the times they knew how to reach the thrombosis services to discuss anything with them, and it was much more intensive. These relations were much more intensive than I would have anticipated beforehand. We collected all follow-up data by telephone with special research nurses, and the way all these bleedings were collected was the same between both groups. So patients with under VKA treatment had at least regular contacts with the thrombosis services. On the other hand, even the NOAC patients very often either consulted their GP or the thrombosis services in case of any bleeding or anything like that. Yeah, so I don't expect a large difference there. As far as the time point on which the bleedings occurred, we actually saw that the lines in the incidence curve start to diverge straight away. The switching point always is a little bit complicated. That's why we, shortly after the trial started, aimed for a little bit of a lower INR before switching over, just to be on the safe side. But you see the curves diverge actually straight away and remain diverging throughout follow-up. So I think the switching moment, of course, is a critical moment. But if you wait for the INR to drop low enough, you will probably be just as safe as somewhere along follow-up.
All right, well, thank you. Well, maybe we find some more points to discuss later when we also have the AZELEA data. So I would very much like to ask Dr. Ruff to present the study. Looking forward to it. And well, please.
Wonderful. So actually, this talk dovetails nicely with FRAIL-AF because it underscores where we are with respect to DOAC therapy for stroke prevention and atrial fibrillation. And just as a reminder, we now have 4 seminal phase 3 trials of the DOACs versus warfarin. And anticoagulation, of course, remains a cornerstone in our treatment to prevent cardioembolic stroke. And we and others were involved in these phase 3 trials. And in general, they showed that DOACs were as effective in reducing ischemic stroke and far safer with respect to serious bleeding, in particular intracranial hemorrhage, which was reduced by 50%. And that really drove the mortality benefit of 10% of DOACs versus warfarin. But as nicely alluded to in our prior discussion, the benefit for major bleeding is less certain. There's variability among the DOACs, and as a class, they increase the risk of major GI bleeding by 25%, which is the most common type of bleeding that we see. And we know that bleeding is still a problem. This is 1-year data from the combined AF patient-level meta-analysis of 5 DOAC trials, which showed that some patients have bleeding risks that exceed 5% per year. And remember, this is a lifelong therapy. And we know from both clinical trials and registries that bleeding, or even the perceived risk of bleeding, drives significant undertreatment of patients. And so this has led to our continued search for an even safer anticoagulant. And factor 11 inhibitors have really emerged as our most promising potential target to uncouple hemostasis on the left which is the ability to form a hemostatic plug in an injured blood vessel and prevent bleeding, from thrombosis on the right, where a pathological thrombus forms in a blood vessel, occluding blood flow, leading to end organ damage. So factor XI inhibitors may therefore be able to provide hemostasis-sparing anticoagulation. And that brings us to abelacimab, which is a highly selective, fully human monoclonal antibody that binds to factor XI and locks it in the inactive state, really preventing the formation of activated factor XI. And in a phase 2 study after total knee replacement, a single dose of IV dose of abelacimab prevented venous thromboembolism by 80% compared to standard of care enoxaparin. And the prevention of venous thromboembolism in phase 2 trials is really the proof of efficacy for how we study anticoagulants in development. And so that brings us to the AZELEA TIMI 71 trial, where our objective was to evaluate the bleeding profile of abelacimab relative to rivaroxaban in patients with atrial fibrillation at moderate to high risk of stroke. So 1,287 patients were ultimately randomized to either abelacimab 150 milligrams sub-Q monthly, abelacimab 90 milligrams sub-Q monthly, or rivaroxaban 20 milligrams daily. The trial was open label with respect to abelacimab versus rivaroxaban, but blinded with respect to abelacimab dose. This was an event-driven trial that was targeting 166 major or clinically relevant non-major bleeds, which was the primary endpoint of this phase 2b study. Key inclusion criteria included age 55 years or above, any history of atrial fibrillation or flutter as long as there was planned indefinite anticoagulation, and either a CHA2DS2-VASc score of 4 or greater, or a CHA2DS2-VASc of 3 if patients had at least one of the following characteristics: planned use of concomitant antiplatelet therapy, or creatinine clearance less than or equal to 50 milliliters per minute. On September 14th in 2023, we were alerted by our independent data monitoring committee that they had unanimously agreed to recommend termination of the AZELEA trial because of a substantially greater than anticipated reduction in major and clinically relevant non-major bleeding in both abelacimab arms compared to rivaroxaban, with a benefit risk favoring abelacimab. Based on this recommendation, we proceeded with orderly closeout of the trial, which is just completed, and the data that I'm presenting to you today, as well as what we presented at the American Heart Association late-breaking clinical trial session, is based on the DMC snapshot. So median follow-up at the time that DMC recommended termination was 1.8 years. At that time, 87 patients had experienced a primary endpoint, which is 52% of the planned 166 primary endpoints. Premature drug discontinuation was less than 5% per year. There were low rates of withdrawal of consent, and almost no patients were lost to follow-up. These patients were characteristic of a moderate to high-risk AF patient population. The median age was 74 years. 44% of the patients were female. The median CHA2DS2-VASc score was 5, with 22% of patients having a CHA2DS2-VASc score of 6 or greater. 15% of patients had a prior stroke, 7% a prior bleed, about 20% of patients with a creatinine clearance less than or equal to 50 milliliters per minute. Unlike the prior DOAC versus warfarin trials, the vast majority of patients in this trial were anticoagulation experienced, which we defined as having been on an anticoagulant in the past for at least 60 days consecutively. So 92% of patients were experienced. The majority had been on a DOAC, 66%. About a quarter of the patients had planned concomitant antiplatelet use for the duration of the trial. Abelacimab achieved very potent inhibition of factor XI with greater than 95% inhibition in both arms. We could see almost complete suppression of factor XI with 150 milligram dose of abelacimab, with 99% inhibition with an interquartile range of essentially 99%, and a 97% inhibition in the abelacimab 90 milligram group with a slightly broader interquartile range. Here we have the Kaplan-Meier curves for the primary endpoint of major or clinically relevant non-major bleeding. As you can see, both abelacimab doses resulted in substantial and highly significant reductions, with a 67% reduction with the 150 milligram dose and a 77% reduction with the 90 milligram dose. If we look at major bleeding alone, it was reduced by 74% in the 150 milligram dose and 81% in the 90 milligram dose. Gastrointestinal bleeding, which, as I mentioned, constitutes the majority of bleeding we see with DOAC therapy, was nearly eliminated with both abelacimab arms. Intracranial hemorrhage was uncommon and similar across the treatment groups, and clinically relevant non-major bleeding was reduced by 61 to 75%. Here I show exploratory outcomes. As I mentioned, in this phase 2b trial, it was powered for bleeding, but here are some of the efficacy exploratory outcomes. Just to comment, the rates of stroke were low. Specifically, there were 25 total strokes across the 3 treatment arms, 22 of which were ischemic. There were numerically more ischemic strokes that were not statistically significant in the abelacimab arms, whereas mortality was numerically but not statistically significantly lower with abelacimab compared to rivaroxaban. Both abelacimab arms resulted in a significant 51% reduction in the net clinical outcome, which comprised of ischemic stroke, systemic embolism, major or clinically relevant non-major bleeds, or all-cause mortality. Abelacimab was well tolerated with similar rates of adverse events, including serious adverse events compared with rivaroxaban, and injection site reactions were uncommon. So in summary, abelacimab provided potent inhibition of factor XI greater than 95% over the dosing interval. There were substantial reductions in bleeding with the 150 milligram dose compared with rivaroxaban, which is the dose being carried forward in phase 3 studies. 67% reduction in major or clinically relevant non-major bleeding, 74% reduction in major bleeding alone, as well as a 93% reduction in major GI bleeding. The efficacy of abelacimab is being studied in the ongoing LILAC-TIMI 76 trial, which is a phase 3 trial, randomized double-blind trial in high-risk patients deemed unsuitable for currently available anticoagulation. And patients will be randomized to either abelacimab 150 milligrams or placebo sub-Q monthly, with a primary endpoint of ischemic stroke or systemic embolism, and a primary safety endpoint of BARC 3C5 bleeding, but of course we'll look at all bleeding endpoints. Thank you.
Thank you for all that work. One question, obviously, that comes to everybody's mind, and also with the discussion we've had lately with the other, with the asundexian trial that has been stopped earlier. What about efficacy? I mean, we have a low stroke rate, 1%. You mentioned in the rivaroxaban arm. That's in the order of magnitude of the Artesia and the NOAA-AFNet trial, where one also discussed that the rate nowadays in these trials seems to be lower than the CHATS-VAS score would suggest. Is that an issue? Is that difficult to beat, actually? And how much do you need? What do you think in your new trial? You have power calculations. How much patients will we need to really prove efficacy?
Yeah, it's a great question, and I think both things are true. We know that in all of the trials in atrial fibrillation across a broad range of sort of populations, that the event rates are lower across the board for both bleeding and in particularly stroke, and lower than what we've seen historically in trials. The rate that we observe here in this trial, about 1% or a little more, is lower than you would have expected in this population. So I do think that it does reflect that these patients are likely getting effective anticoagulation. The one thing this trial can't answer, and obviously we'll see the results of Oceanic AF when they're reported, is what the relative efficacy in this case of abelacimab is compared to a DOAC. Obviously, there's a concern, given that the Data Monitoring Committee stopped Oceanic AF for inferior efficacy, that what does this mean as a class for factor XI inhibition? These data, I think, really seal the deal that if factor XI or factor XIa inhibition is remarkably safe, but what about the efficacy? And so I think factor 11, 11A inhibitors are likely effective, but it depends very much at the dose. And I think we don't know until all the phase 3 trials report, are they as good as the DOACs? And as you mentioned, in my opinion, because the stroke rates are so low, I do not think the factor 11 or 11A inhibitors can be better than the DOACs. The residual stroke rate is less than 1% per year. And only a portion of that residual stroke is cardioembolic and therefore modifiable anticoagulant therapy. So I think the best that we could hope for are that these agents have similar efficacy for a DOAC. But I think we have to be prepared that it's possible that they don't quite have as great efficacy as the DOACs. And as you mentioned here, there were numerically more strokes here, a small trial with respect to efficacy. We know asundexian was inferior. And I think there are a couple of things. One, as a class, maybe factor 11 or 11A is not as effective. We won't know until all the phase 3 trials report. I also think that there likely are important differences across the class with respect to efficacy, which wasn't true for the DOACs. We know that the potency of factor 11 inhibition varies across the 3 agents being studied for stroke prevention and atrial fibrillation. And I suspect that that potency does translate to clinical efficacy. And it's also possible that how you inhibit factor 11 or 11A is important. Whether you inhibit factor 11 and prevent any activated factor 11 from being formed, or whether you allow factor 11 to become activated and then try to inhibit it. But until we have all of the data from the phase 3 trials, we won't know that answer. But I think it's a legitimate question, you know, what truly is the efficacy going to be for this class? But it certainly is incredibly safe. And if it turns out to be an effective class, that will be an important advance for our patients.
Took the word away from Dr. Doorn. Van Doorn, I actually wanted to give the word back to the Netherlands as we did earlier. So sorry, I hope I haven't taken the question away from you, Dr. Van Doorn. What's your thoughts on the AZELEA trial?
Yeah, thank you very much. Very promising results, very interesting, Dr. Ruff. And maybe I'll take the discussion a little bit further and would like to ask you to speculate on what if the effectiveness maybe is good enough to carry on either using or studying the factor 11 inhibitors. Based on maybe your expertise, could you identify a patient group, for instance, that would benefit first? Are these, because bleeding and stroke risks go hand in hand so much? Could you speculate on that? Which patients may be suitable?
Yeah, I think it's a great question. And in our preliminary results, you know, we haven't seen any heterogeneity with respect to the relative benefit of the bleeding reduction compared to, in this case, rivaroxaban. But obviously, the phase 3 trials will have great power for that. But I think you raised a legitimate question. In like warfarin or vitamin K antagonists, there are many patients who are on a DOAC and do quite well. We know that bleeding is a real issue, but many patients don't bleed. And so I think it's legitimate where you have a whole new class and, you know, cost aspects that one would imagine that we should try to think about the population that on an absolute term are the most likely to benefit from an anticoagulant that, if effective, is remarkably safe. Clearly, you know, the population that we're studying in LILAC is one example. Those patients where it's been already decided that they can't tolerate or haven't tolerated standard of care anticoagulation, a vitamin K antagonist, or a DOAC. Those patients are at 5-fold the risk of stroke and aren't on anything. That seems to be the biggest unmet need. But then I think when you take into DOAC or VKA eligible patients, it's going to be some sort of bleeding criteria. The easiest is probably patients who have been on an anticoagulant and have bled before. And so that seems to be particularly GI bleeding, which is almost eliminated with factor 11 inhibition. So I think that may be a population that we first grab onto. But as you said, the tricky part with our bleeding risk stratification is the same patients who are at high bleeding risk are at high risk of stroke. And so I think we have to get better at fine-tuning our risk assessment for bleeding. But I see exactly what you envision, that this is not going to be a broad, you know, let's switch everybody over to this new class of medications if approved, but it'll be patients who aren't on anything, and then patients who have bled before or who we deem to be at high risk of bleeding, and say these other patients with low absolute rates of bleeding on a DOAC or a VKA, they're probably doing quite well. And as you mentioned, Dr. Sherman, that these agents are unlikely to be more effective. So efficacy won't be sort of a reason to switch.
Yeah, thank you.
You mentioned that the 150 milligram dose will be carried forward. Why is that? Because to me, it looks that the lower dose seems to be even safer.
Yeah, I think it's a great question. I mean, one of the things that we know from both vitamin K antagonists or DOACs is that there was, with the time and therapeutic range and the INR targets, as well as the dose selection for the DOACs, is that these drugs were never used with their highest efficacy because the bleeding wasn't tolerable. So if you push the dose up in the dose ranging from the factor, say 10A or the 2A inhibitors, you got intolerable bleeding. So there was this balance that you had to pick a lower dose where the bleeding was tolerable. What's interesting here is even with max inhibition of factor 11, where you almost completely recapitulate congenital factor 11 deficiency, that's remarkably safe. So you're not paying really much of a penalty going from lower levels of inhibition to max inhibition. And I think especially for this field, if there's a question about efficacy, that you're going to want to be with a factor 11 or 11A inhibitor at max inhibition. You're not going to want to leave any efficacy on the table. And even with the 150 milligrams where you get complete suppression, that appears remarkably safe. We're talking about 60 to 80% reductions in various bleeding composites. So I think that ends up being the main driver is you want as much efficacy as you can. That's why an anticoagulant is being prescribed. And even with max inhibition, it's really safe. And so I think that probably, for all things considered, is likely the optimal strategy. And I will say, based on at least what's in the public domain, the consensus is that asundexian was likely underdosed. That may be part of the reason why that trial was stopped. And so obviously we'll have to see when those results come out. But I think the move will be, we got to make sure that we're using, as much inhibition as possible, and even going to full inhibition appears safe. But obviously we won't know the answer to that question until we have the phase 3 trials.
That makes sense. One more question from my side. What about kidney patients? Because it's always a very big issue for us with CKD patients, especially with a GFR below 15. And you had quite a big portion of patients with a decreased GFR at least.
I think a couple of important points. One, because bleeding is so low, and we know that patients with advanced CKD have very high rates of bleeding, that advantage would be preserved. The one also, I think, important thing about abelacimab in comparison to the factor 11A inhibitors, which are small molecules, is there's no renal clearance. And so those, you can use the monoclonal antibody in patients with even end-stage renal disease, and there would be no clearance issues, whether you would have to incorporate dose reductions, say for asundexian or milvexian. And as you are aware, these agents are actually being studied in patients with end-stage renal disease on hemodialysis, even without atrial fibrillation, because one of, the mechanism of factor 11 or 11A is in that contact activation. And we know there's a lot of clotting, say on dialysis, during dialysis. So there's some thought that even without atrial fibrillation, that inhibiting factor 11 will be very important for preventing clotting in dialysis circuits or vascular access. And so I think these drugs may be quite appealing for patients with advanced CKD because the bleeding's so low. These patients have a lot of bleeding. Many of them aren't even on an anticoagulant. And particularly abelacimab has no renal clearance, so no issues giving it to patients no matter what their GFR is, even if they're on end-stage renal disease. And factor 11 is probably better than factor 10, preventing clotting in dialysis circuits. So I think this is a potentially very promising class of agents for those patients.
And another patient group might be outside pure cardiology patients with cancer-associated thrombosis, where there are also phase 3 studies ongoing. So we discussed this CAT with Professor Maye, Professor McBain, Professor Bertoletti in the last years. And I guess similar to end-stage kidney disease patients, these patients are also characterized by their high bleeding risk under standard treatment.
That's absolutely. And I will say abelacimab in particular actually has 2 other phase 3 trials that are active and recruiting for cancer-associated VTE. One particularly in GI malignancy. And as we know, the DOACs are not great for GI malignancies because they tend to cause more GI bleeding, which is a major problem if you have GI malignancy, and one is in a broader cancer population. But I think you're absolutely right that there's a lot of potential appeal in cancer-associated VTE. Those patients have high rates of thrombosis, bleeding, and also they have a high rates of port thrombosis too, which factor 11 inhibitors are thought to be particularly effective. So we are eagerly anticipating the results of those two trials as well.
Are there any large phase 3 studies ongoing comparing NOACs and factor 11 inhibitors right now? Because LILAC is rather, again, similar to elder care, comparing anticoagulation where there's no anticoagulation. Oceanic AF has been stopped. There are many companies behind these products. Are any other products tested in phase 3 studies right now?
Exactly as you mentioned, there were only 3 factor 11 or 11A inhibitors that were actively in phase 3 for stroke prevention, atrial fibrillation. LILAC, as you mentioned, which is unique in that it's a placebo-controlled patient population. And then the 2 small molecule factor 11A inhibitor trials were doing active comparator against apixaban for stroke prevention, atrial fibrillation. The largest being asundexian in the Oceanic AF study, as we alluded to. That trial has been stopped, and there is one remaining large phase 3 trial, active comparator against apixaban, very similar patient population to Oceanic AF. That's called Librexia AF. That's a trial with the other small molecule factor 11A inhibitor, milvexian. And so the 2 phase 3 trials that are currently ongoing are LILAC TIMI 76 and the Librexia AF. But as you mentioned, there are other agents that are in development that are sort of contemplating their phase 3F trial, so we may have more, but those are the only 2 that are currently ongoing.
So one challenge surely is that you apply this medication just once a month. So what to do if patients undergo either surgery or have acute bleeding? Are there any antidotes? Do we need any antidotes here?
It's a great question, and we're actually hoping to present the periprocedural data at an upcoming scientific meeting. Those periprocedural bleeds are included in the primary bleeding analysis. So the rates overall were generally low, including periprocedural bleeding. But you ask a very important question. What we've learned, obviously, we had hundreds of procedures that were done in this trial. 2/3 of the patients were on abelacimab. And over 80% of the time, these procedures were done fully therapeutic on abelacimab within 30 days of their last dose. And remarkably, almost no patients bled. And so with the DOACs, as you know, which are safest in general, anticoagulants, we have to stop them routinely for all sorts of procedures, where patients in the AZELEA trial were getting procedures fully therapeutic on their abelacimab, and we had low rates of bleeding. So I think it could change, if these agents are approved and are so safe, it could change how we manage anticoagulation because there may be no need to stop, that bleeding is so low. We did recommend that some common antihemostatic agents such as tranexamic acid is effective as prophylaxis or prevention of bleeding. In patients that have serious bleeding, especially in Israel, where there's a higher population of congenital factor 11 deficiency, low dose recombinant factor 7A is also effective. But I will say in our trial, hardly any of that was used. Most patients had these procedures that were fully therapeutic, and bleeding was incredibly low. So it may change how we manage periprocedural bleeding, but we look forward to presenting that data at an upcoming meeting.
I have 2 more questions. So the first one would be, again, on AZELEA. You selectively pick patients at high risk. CHECK-VASc was higher than in some NOAC trials. So was this to have patients at high risk for bleeding, or what was the idea behind it?
Exactly. As Professor Van Doorn mentioned, we know that stroke risk and bleeding risk really go hand to hand. And Chad's VAS score predicts stroke and bleeding, and so does HASBLED. And so, based on sort of our modeling calculations, we wanted to make sure we were studying a population that would give reassurance to the medical community, so wanted them to have a high risk of both stroke or bleeding. And obviously for this phase 2b trial that was powered for bleeding, that did ensure that the bleeding event rates would be high enough that we'd be able to observe a difference. Of course, as we noted, all of the event rates, despite having a CHA2DS2-VASc score median of 5, were quite low. This sort of mimics a CHA2DS2-VASc score of 5 is very similar to the ROCKET-AF study, if you look at what their median CHA2DS2-VASc score would have been. But our event rates for stroke and bleeding were quite a bit lower, which just speaks to sort of the evolution of anticoagulant care. We should give ourselves some credit that our patients are actually doing better on these therapies now that we've been using them for over a decade.
So my last question, Stefan. As for any novel drug class, there's a lot of speculation from lab studies, and here there has been some discussion about potential unwanted myocardial effects via the SMAD1 or 5 pathway. On the other hand, potentially some vascular protective effects via anti-inflammatory pathways. Any thoughts whether this may become clinical relevant, or do we just have to await the result from the phase 3 studies?
It's a great question. In the clinical development, there has been no signal with respect to, say, cardiac events, myocardial infarction, et cetera, either pro or con the factor 11 inhibitor. The rates of myocardial infarction in our trial, which is the largest experience that's public to date, was vanishingly low. And we do know that DOACs, in particular rivaroxaban, has an approval for ASCVD, although at a lower dose. And so we certainly haven't seen any adverse signal in clinical development, but obviously not powered or selected for population. I do think we will really only know that answer until the milvexian CAD ACS trial presents. That's the only agents that's being studied in a phase 3 trial for ASCVD in general. That's also a very large study that's enrolling patients after ACS. So I think we will have that answer, whether inhibiting factor 11 is good or bad with respect to cardiac events. But I think we've been reassured so far that we certainly haven't seen any signal that there's been an adverse effect on the heart. But obviously, until we have much larger studies, we'll need that for reassurance.
Just quickly to extend on that, could you speculate on the aspirin? You have had 16% on aspirin, which is quite a bit in an AF population. Yeah. Was that post-PCI? Wouldn't one recommend P2Y12 inhibitor instead? Or what was the reason for the aspirin?
Yeah, we had a mix. I mean, one of the things that we wanted to be careful of is as everyone's aware, often if you say a patient's on aspirin, they'll stop the aspirin once they're in the study. And so we wanted to be very clear that the patients had to have an indication for continued antiplatelet therapy in addition to their full dose anticoagulants. So the vast majority, in fact, almost all of those patients had concomitant coronary disease. And it was a mix of patients who were post-ACS, as well as some patients who had chronic CAD, but perhaps they had complex coronary disease where, say they had, left main or bifurcation stenting, and they had a lot of athero and a lot of hardware, and they had a longer duration of antiplatelet therapy. We did leave that up entirely to the discretion of the investigator. So we recognize there's a lot of heterogeneity there was very little depth, as you might expect from the guidelines, but there was a lot of heterogeneity with which antiplatelet agent, when you had concomitant coronary disease, that one used, low dose aspirin or P2Y12 inhibitor. And I suspect that just reflects sort of the heterogeneity in practice, as well as across the regions and countries that were enrolled. But it was almost entirely in patients who had recent coronary disease.
Okay, I think as you realize, the two of you, we can probably go on for a long time asking you more and more questions. As with all good research project, it opens up sometimes more questions than answers, and we're very keen on what will come from the studies mentioned. Thank you so much for your work you've been doing and you are still going to be doing, and for your time for this interview. And it's been great pleasure talking to you. Thank you.
Thank you so much. Really enjoyed it.
Thank you very much.